It's a pleasure to open this live cast session. And without further delay, I would invite our colleague to present the first case, and then we join the NG suit.
Hello, everyone. In Nenov, and I'm going to present the first case. It's about 45-year-old male patient with risk factors, hypertension, dyslipidemia, and he's current smoker, who is with high-grade stable angina. The patient is with known coronary artery disease, left main entry vessel disease. April 2021, he was with anterior myocardial infarction, and it was performed primary PCIF LAD with drug-eluting balloon. From ECG, we have sinus rhythm with negative T waves in third and AVF leads, preserved left ventricle function with normal kinetics and valve function. You can appreciate here the coronary anatomy, distal left main stenosis, Medina type 111, with osteo lesions of LAD and circumflex artery. It's dominant circumflex artery with proximal stenosis of PD. Proximal stenosis of the first diagonal branch, you can see it from the spider view. Here, mid-LAD stenosis and second diagonal branch with osteostenosis. This is a small right coronary artery with occlusion in mid-segment. We performed stress echo with 5 segments inducible in ischemia in the territory of circumflex artery and right coronary artery. It's the whole inferior wall, basal and mid-inferior septum. CABG was offered to the patient, but he declined it. That's the first case.
With the cath lab now. Hello, George. Dear colleagues, can you hear us?
Yes, we hear you very well.
Okay.
First of all, I have to really thank you for inviting me back here. It's a great pleasure to both Dr. Jeleva and Dr. Vasiliev. Very great pleasure to be among friends after some time and to meet all together. So I think that the case was introduced?
Yes.
Okay.
So we are waiting for your strategy.
So, can you see the angiogram?
Yeah.
It's still framed now, but
Okay.
yeah, we see it moving.
So we have a setup. We have a 7 French sheath and 7 French guiding catheter, EB JL4 or 3.5. Sorry, it's a 3.5. So that's our setup here for the case. I'm going to show you again the images that we have got. The patient has an acute coronary syndrome. He was balloon treated with DEB in the middle AD. There is a lesion over there at the takeoff of this big septal branch. That's also beyond the left main one question that we have been discussing in between ourselves. There is also, as far as I see here, better now a diagonal that has an osteostenosis also. That's also something to be considered for the treatment plan. And this is a cranial projection. This is a caudal projection that you can see that definitely both the ostium of the LAD and the ostium of this dominant circumflex is involved. And there is also a kind of a branch that it's not clear from this position whether it's an intermediate or a diagonal or a marginal, but you see that we have a good ejection fraction in this case, which is also a very big denominator of what we want to do. And here it's a spider that shows that this intermediate branch is a rather proximal diagonal. This branch actually a proximal diagonal rather than an rather than an intermediate branch or a marginal, from what we can say from this picture. So we said, based also on what was heard, that we're going to do imaging in both vessels before any decision, and then we will discuss with you what to do. So from the imaging, from the angiographic imaging, we do have an idea, or we have the plan. If we haven't done an IVUS, we could have told you what we would have done. And, or actually, Dr. Jeleva, what do you think? Should we say what would our plan would have been before the imaging and see whether we're going to modify that?
Yes.
So for ourselves, and we want also your opinion before we do the imaging. What we see here is that, at least for the left main, because from a previous film I was more focused also on the entire part of the proximal LAD, because I see that the lesion, or I think that the lesion at the takeoff of the septal branch is also significant. We're planning to do a crossover, so start from the middle LAD with a kind of a 3-0 stent to reach the proximal LAD, and they take a 3-5 to 4-0 to cover all the way to the ostium. So we will start with a crossover, not in a way that it's going to be provisional. Our decision from the very beginning is that this is going to be a two-strategy procedure, two-stent procedure, but we, from the takeoff of this circumflex and the severity of the stenosis, our estimation, the angiographic estimation, is that it's not going to be compromised, the circ, in a way that it's going to be occluded. So standing from middle AD all the way to the ostium of the left main, afterwards pot, and then getting access to the distal strut of circ, and then go for a tap stenting, kissing, and final pot. So that's our geographic strategy. Dr. Jeleva, I don't know if you have to add something to that.
I think this is our strategy, because the backup of it is that on stress echo, it was proven that the first ischemia was emerged at the territory of the circ.
Do you have any comment? Okay, initiate, let's start it. From your side?
Let's go
George?
distally and make a pullback.
I have one, so I will do a provisional strategy as you plan.
We don't hear you very well, Yves.
So is it working or not?
Now better, yes, thank you.
You hear me?
Yes.
Yes, so I will do a provisional strategy as you, and with double stenting, of course. But having seen the expertise in ischemia, I may do maybe completely the opposite. I will stent from ostium to circumflex with a long stent. You have to cover a long lesion. And after that, I will exchange, do a kiss, and look what to do in the LAD. I think the proximal part of the LAD, the lesion is relatively short, much shorter than the circumflex one. So this is the same strategy, but not beginning with the same vessel.
Okay.
We have to.
I do believe that. So
we have to do it manually. We can start.
Okay, but let's. Okay, all right.
So
both more or less we're talking about the same technique, which is crossover, but you're saying that you might even accept provisional for the ostium of the LAD. Correct?
Yeah, but I call it provisional. I have to call following the classification A. So beginning with the crossover. Good. But the intention is very clear to put two stents, one in LAD, one in circ.
All right. So do you see the IVUS? We have the IVUS in we have the IVUS in the LAD.
We don't see it clearly.
We don't have on the screen.
Can you show the IVUS? So,
yeah. Yes.
Is going. We're going to do a manual pullback there.
Yeah. Okay.
We covered also the distal lesion.
George.
Yes.
Tell me when you're ready.
I'm ready.
You have to pull it from here.
It's okay. Yes. All right. So can we start?
Okay. Yes, we can start.
Okay. So we start the pullback here. We're going to do a manual pullback. So we're in the distal LAD, very minimal disease over there. Here is the lesion, I think, into the takeoff of the septal. Let's see if we're going to see the vessel there. Negative remodeling. Septal is coming there, you see it. And there. So I think over there definitely we have a very small MLA. Do you agree on that?
Yeah, yes.
Should we measure there, Dr. Jeleva, or we can do it later? Okay. So let's pull back a little bit. The entire proximal LAD is very diffusely diseased. This is the first diagonal. We cannot judge very well from this projection whether it's very severely diseased, but geographically it was. Proximal LAD, we're going to see the dimensions of the vessel. We're coming more proximal. The vessel is getting bigger. It's a very strange appearance, where there is a plug and then there is an echolucent area without calcification over there. Here is the proximal LAD. Circ is coming, the wire, and this is the left main, very diffusely diseased, not very long, and we enter the circ, the aorta. Okay. Should we analyze here, Valery?
Yes, that is what we are going to do.
So let's show the people. I think you're in front. So if you go from the other side, can you see the IVUS now?
Yeah, we see.
Yeah.
Great. We're going to do, after some analysis here, we're going to do the pullback in the circ also, with main focus on the ostium of the circ. This is a very nice system. You see that it is very friendly to use.
George, what is puzzling us that you have a diffuse disease in the LAD and no proof of ischemia, and you plan to put a lot of metal in there?
We cannot hear you very well.
I say that what is puzzling to us that you have diffuse disease in the LAD and no proof of ischemia at all, and you are planning to put a lot of metal inside.
The LAD is really very diffusely diseased.
Yeah,
And,
how was done the expertise of ischemia? Was it stress echo? Was it
Stress echo.
yeah, stress echo?
Yeah.
Sometimes when you have left main, we see that in stress echo I don't do, but in MRI and also in isotope, when you have a left main lesion, sometimes you have equilibrated ischemia, and you don't see the true extension of ischemia. We see a dominant vessel only.
I mean that just to when we are doing the stress echo and when there is ischemia emerging in one side of the in one vessel territory, we are stopping it, and this is not that we have proven ischemia in the left circumflex do not preclude that there is a lack of ischemia in the AOD. That's why we are making the IVUS, and we are going to assess the minimal lumen area, the ostium of AOD, which in my view seems quite diseased. This is the distal part of AOD with minimal.
the MLA is 6.9.
6.9, and the
So
diameters around 3.
Which is very acceptable, I think.
Yes, and we are moving to the proximal part. Here, this is the place of the septal.
A little bit more proximal. I think.
Yes, it is on the second
Here we're
bookmark.
talking. Yeah, that's exactly the
This
takeoff
is-
of this.
This is the takeoff of the septum. There is a small diagonal.
Yes.
If we measure this, although this is the diagonal, this is 2.5, and this is more proximal to the vessel that we
Exactly.
have seen distally. If we make it absolutely correctly without the influence of the carina, I think it is going to be the same.
Yeah. No, it's very diffusely diseased there. There's no
Here?
doubt. Yes, exactly. This is very generous. Yeah.
Yes, this is
Yeah,
absolutely.
exactly.
So
So
still
it's
it is
around
3,
it's
but
around 3 max.
but
2.5,
having in mind
yes.
that we have the and the diameter is 1.5.
Yeah.
I mean,
Yeah.
if we assume that the distal, the previous measurement was our reference diameter, so we are coming, this is again
the
proximal
diagonal, yeah.
LED, and you can appreciate that it is really 3.5.
Valery, can we go a little bit back more distally? Because this is a strange appearance. Leave it there, it's good, it's good. What I see here is not what we expect you to see. This might have been the place of the previous treatment.
Probably.
Because I don't know if you agree about that, but this is not what you expect to see. There is this collusion tissue between 6 to 9 or 5 to 9. Just like this is something probably related to drug-eluting balloon treatment.
Probably, according to during the acute
yeah,
event.
exactly. You see that what I mean, eh?
Yes, but there is some calcium which is doing some shadowing of the. We are coming to the proximal part.
This is proximal LAD. Valery, let's measure a little bit before we go to the circ. Go a little bit just distal to the carina and measure a little bit. Okay, let's measure here, not the MLA, but let's measure the vessel diameters.
So if we make it like this.
Yeah, go to the externals just to see what the vessel is, how big the vessel is, because definitely this is around 3.9
a little
to
bit
4.5.
What was?
So is it the media to media?
Yeah, this media to media is 4x4. So the ostium of the LAD is a 4-row vessel.
No, I don't agree with you, George.
No, I mean...
This is a remodel vessel with a diameter of 4.
Yeah.
And if you use this diameter to do a crossover from LED from left main to LED, it will close the circ, even if it's not very tight. So I think it's important to look just distal to this. What is the diameter of the vessel in a relatively normal place?
You see here, this is more distal, Valery, or more proximal?
More distal.
So go a little bit further, because the vessel is much bigger. If you see that here, simply I believe that from the previous treatment, I think you can appreciate that. Of course, there is some acoustic shadowing, but the vessel over there is still, it's bigger than 4. So if I make a prediction there, I think that we will see, of course, the diameter of the left main, but we have also to see what kind of stents and how we're going to overexpand them in the direction of the left main. Definitely the LAD is serious, Valery, there is no doubt about that. Let's go a little bit to the left main to measure.
This is the carina.
Okay.
This is the wire into the circ.
Let's see the diameter of the left main just to see how far we have to go. Of course, it's a very short left main, but yeah.
But if we estimate this, is the correct? Do you agree on this measurement?
This is the MLA, which is 6.8 for the left main, but the left main was not
the diameter.
Itself.
I should correct it in a way.
Yeah.
The MLA.
What is the diameter?
6.5. The left main per se itself was not very significantly diseased, but the treatment-wise is a bifurcation. Maybe you can say it at 0.11.
I think that we have a plaque in the left main there.
Yeah.
Sorry, if?
We have plaque in the left main, no? The left main is disease or remodeled because it's small.
Yeah. There is a lot of disease.
So there's a lot of disease. My point is, if you choose to implant directly a stent with the same diameter in the left main as in LED, you will close the circ. So you have a lot of disease here. So if you deliver a stent which is slightly under-deployed, the first deployment, I mean, the stent won't move. It will crash in the material. After that, you do a pot. After that, you redo an IVUS to see how to optimize. And doing that, you will preserve the circ if you choose to send the circ as a second vessel.
So this is a measurement that we have made in the left main immediately after the circ. You can see this is the circ and this is the second right. And this measurement, the minimal lumen area.
We don't see it. We don't see it.
It is 4.6, but still we are going to measure again the left main coming from the circ.
Okay. Already we have created.
If I have to resume it in my view, we have severe diseased AOD in proximal and let's say mid segment with a diameter of about 3, as George estimated, and we have, in my view, significant left main disease, a short one, with a minimal woman diameter around 4.6.
So this is already a very productive discussion, because we all agree that the distal stent should be around 2.75. We will discuss about the technique, whether we're going to stand in the direction of the circle or not. Based on what I see, I think I remain in my initial strategy. But one thing that it came a little bit under attention during this discussion is how big the proximal stent should be. And I think Yves proposes a 3.5.
Oh, no. Yeah, 3.5, but we choose a stent with the potential to go to 4.5.
Yeah, that's the proposal. And then I think this is a very logical, because the left main is not 5. If the left main was 5.3, 5.4, I would have preferred a bigger stent in order to compensate for the proximal diameter. But based on what we saw now, a 3.5 stent of whichever brand accommodates very easily a 4.5 post-dilatation.
Yeah, you have another, excuse me, George, you have another option.
Yes.
Is to take a 4.0, deploy the stent at 6 to 8 atmosphere, which will be in the proximal LED probably 3.6, 3.7, and then fully optimize to 4.5 with the pod.
Yeah,
so this is another way to see.
But that's exactly what was my intention. My initial intention was to take a 4.0 stent, deploy that not in high pressure to protect the circ, and then to have a post-dilatation with a 4.5. So more or less, we're on the same page. And let's see now the ostium of the circ. I'll go a little bit caudal now. Let's see what kind of information we're going to get on the circumflex. I'm sorry. I think that's enough there.
Yeah.
All right.
Maybe a bit more.
No?
Forward.
Sorry.
A bit more distal, George, I think.
Yeah, it is, and I think if you go back there, there is a vessel that it is aneurysmatic after the mid part of the circ, and definitely I will not consider that
I see.
as I don't want to go over there. I will stay within the first
marginal
15 millimeters of the circ, and I will take as a reference what comes out of there. The vessel is very diffusely diseased.
I'm ready, George.
Okay, so we're starting the pullback. Yeah, I will go a little bit more proximal. We want the reference. So, okay, Valerie, let's start.
Yes,
we already started?
Yes. But
Okay.
I will make a bookmark here.
That's good. That's the LED. And the left main is really short. Okay. There is calcification in the ostium of the circ, no doubt about that, more than the LAD. And let's see what kind of information we have over there.
So this is the vessel here. We have it.
We can see the ibis.
Do you see it?
No? Yeah, not.
Just a second to see the... Do you see it now?
Yeah.
That's good.
Where it is?
Distal.
Distal.
Yeah, this is the distal reference, as we said. This is just after the stenotic part. It's around 20 millimeters distal from the bifurcation.
This is approximately, of course, it could be done better, but still we have an idea.
9.5. Okay, so we're coming more proximal to the bifurcated. You see here that there is a lot of plug.
We can hear the values
Yeah.
very well seen.
Let's see there, Valery, because somewhere there we want to see also. Why don't you take the external part just to see how big the vessel is? I think it's around 4. Yeah. What's the diameter outer? 3.9 versus 4.2. So it's a 4.0 vessel there. Okay.
Probably.
So we have a 4.0 circumflex, a 4.0 LED,
Yeah.
and calculation of finesse low is make it 4.6 in the left main, or 5.2 in the left main, 5.
At least.
Yeah, something like that. So I do believe that we should start potentially with stands 2.75 for the distal, 4.0 for a proximal LED, potting with 4.5, take a 4.0 stand or 3.5 in the circ. The final kiss should be with 2 stands of two balloons with 4.0, and we make the final pot with 5.0.
Yeah.
That's
Yeah,
how
I will do
describe
that.
it.
I will do that. So
Yeah.
the last question: how long is the lesion in LED? Much longer than in circ.
We did manual pullback,
so
so in
begin-
that respect, we cannot calculate from IVUS.
No,
So
but
we
we
have
see,
to
we
be-
see it. We see it. So here, what we have seen is that the lesion in LED is much longer than in
Yeah, yeah, yeah.
circumflex. So if with a longer lesion in circumflex, I would have chosen probably to go to the circumflex because of the curve.
Yes.
But I'm sure that with the plan you will implant first left main to LED and then go to the circumflex without any problem.
I will stand the distal LED first with a 2.75 by 30 something stand. Can you give me 2.75 32? 32? Dr. Jeleva, what
Yes.
stand would you suggest, or any suggestion from the panel?
For the left main, a stent with a very large deployment. So you have, I think you have several now.
Well, we have many stands that they can be both dilated with
Yeah, of
5.0.
course.
It can be an Onyx, it can be an Orsiro, it can be a
Science too.
it can be a Zions. I think, I don't know. Dr. Jeleva, as the host, you choose the stand for us.
Any proposals? Okay, let's go for Science.
Okay, 2.75, 30 something.
33.
I'm feeling confident about direct stenting.
George, another question we can discuss.
Yes.
Of course, this is to discuss. I am here for this. Is that to treat proximally before distally for the LED. And the advantage of this is that you can manage the overlapping.
I didn't understand the comment. Can you repeat that, please?
If you do the proximal part, left main and proximal part on LED
Yes.
first, then you will be able to manage the overlapping. If you do
Yes.
the distal first, you are not able to manage the overlapping. You just have to maybe with a measurement with a wire, or I don't know. So that's another option. This is well aligned. Of
Yes.
course, you have a very small risk that you are not able to go with the distal stent. But really,
I think that I chose 30, that they will give me good options in between to choose in between stents, and we are going to always risk a little bit of overlap, maybe a little bit more from the strategy that you are describing. But as I said, what I have and the reason that I'm going to do the distal standing first is because always there is a risk in the left main that you run into problems, and then with the circ, and then this one I don't want to. So I feel confident about that we're going to be able to do good sizing, and there is also a guide of a good diagonal there. It might be another bifurcation. We're going to see how it is. So I will insist on the strategy of distal first. The other thing that I would like to know, should we put the balloon and trap it into the circ or not?
Oh, no, personally, I won't do that. I know these techniques, protection with balloon, protection with microcat also, but no. I don't think this is necessary in this specific case.
Yeah.
And if you do this technique of protecting with a balloon, you have to do it with a small balloon, because it's just to give back flow. It's not to, of course, to treat the lesion.
Yeah.
The wrong wire.
I put the stand in the wrong wire.
Just a tip for this, probably you all know, but in my place, we are putting the wire at the same place as on the screen in this projection. So the LED wire is distal to you, and the circumflex wire proximal to you. So you always know on which wire you have to put the balloon or the stand.
Yeah, I think that's a ritual. Everybody has its own. So in that respect, I always exchange, because we had the gap of the eye, that's why I confused the wires, give a little bit of contrast. But what you suggest is a good thing. We have to go marker proximal. I will go over there. The main thing that I don't want here, and that's what you were saying, we might have more overlap, but we don't want to double overlap the diagonal. Okay, a little bit of contrast. I think we have enough length there. I find that a good position. Okay, take it up there. Okay. 12. Safe fluoro, please. Okay, and down.
Another one?
Go 1820 there. That's good. Down. Everything is calm here. We don't see any ST elevation from the diagonal. A little bit of a small puff. Contrast. Okay, we're good.
Good.
So, if I take it over there, we are in a cranial projection, so we see the carina. Give me a little bit of contrast. So we want more proximal. I don't want contrast now. Let me just see where it is sitting now. This is a 30. What kind of length was that?
33.
A bit shorter.
I think a 28 millimeter stand will be just perfect.
Yeah.
With minimal overlap. I'll make now a small film with contrast. Contrast? Yeah, I'm covering the entire left main with in this projection. I think that the overlap is 5 millimeters.
But I think
yes.
It's a nice length too, because
33. What is the length before 33? It's 28.
28.
What do you suggest? Another 33 with this overlap, or we can go a little bit more proximal? Yes. Another 33. 4-0, 33.
I think that this overlap is okay. I think. And 33
I mean,
will be okay, yeah, because 28 will be a little bit.
The bifurcation, and we don't risk
No.
1 or 2 millimeters.
4-0. Let's challenge the case by means of, anyway, we were going to make a 5-0 dilatation in the ostium as a post-pod. I would follow the suggestion of Yves that we take a 4-0 to low atmospheres. We're going to implant to 6-8 max, and then we will optimize with post-dilatations after getting access to the circuit.
3.5 we're going to optimize, and after that...
Let's take a 4-0 and we'll see.
It was interesting that on Naivus there was not a big lesion on the circ, and I will be very much interested what is going to happen when we make a kissing down there.
Yes.
And if it is looking good, we can just estimate the region functionally. That is what you proposed in the beginning.
Yeah, we can do that. I think the guide is sitting well there. It's outside the left main, so I will not push it for more support. I don't expect any big problems of stenting. Advancement, it's okay there. Now we'll correct the guide a little bit.
A bit of caudal will be easiest for us to separate the
Yeah,
sock and the lady?
I prefer the cranial projections because we see the upper rim of the left main much better. A little bit of contrast, please, here. We can go a little bit more back. I will be happy to go a little bit more back here. Personally, I don't need a caudal myself. Phil?
Yeah.
And a little bit more back.
Maybe a wheel.
What do you think?
That's good.
Okay, let's take it up.
6, 8.
6, 8 maximum. The lesion is soft, down.
8 atmospheres.
Yeah, it's
Down.
perfect. It's perfect. If it's not enough, you will correct that later. So it's
Yeah,
not a
yeah, yeah,
problem.
of course, of course.
But this another point is that this is this kind of left means that you should not go definitely and cover the ostium because it's very wide and it is not
Yeah.
diseased.
No, but I will go for pressure a little bit higher. Go to 12 now. I would like to dilate because we will take a score 4.5. Let's take a 4.5
C3 ped date.
down. Let's take a 4.5 short. But we really need a very short one because the left main is short. I
Yes.
will go for an 8.
Yes, but you know this is short, but you can inflate a part in the aorta.
Part
So
into the aorta, it is not.
yeah, it's not a real problem.
Yeah, yeah.
Well, just a question from me, Fouladvand.
Yes.
About the post dilatation of the stent before doing the distal post dilatation, distal optimization. Later.
We will fix these things. Let's focus now on the bifurcation, and then we will get access and we will do all the nice things around
I
it.
think it is mandatory because we have inflated the furrow stent to a very low atmosphere state, and the proximal part of the AVD is not well deployed.
But not with a 4.5 balloon.
No. I mean after that.
Yes, of course. No. But also, I do believe that there is also something else. We have the distal stent as 2.75 and the proximal stent as 4.0. So all of this tapering has to be smoothened.
I presume that
This is the lady.
I presume that
yeah.
if you have now a problem with the sock, we will know. I presume the EKG is normal or near normal.
Yeah, as I told you, for these things, for me, many things that they're very important. How do I go caudal, Dr. Jeleva, from? Ah, that's good. Let's go caudal now to be able to assess the bifurcation better. Thank you very much. I have developed these kind of, let's say, skills not to need to see a lot. Is that the circ? I'm not sure.
And the wire to circle.
This is sock
okay.
wire, yeah.
Let me see Dr. Jeleva a little bit. I am continuously making mistakes because somehow I'm confusing myself on the wires. It's okay, we have a relaxed environment, but sometimes if you're under pressure, this might be problematic.
But this is something you have to think before pushing. You know, that's important for the audience. Then when you feel a resistance, that there is a good reason normally,
Exactly.
especially in a 4.0 stent. Huh?
Not only that, but I mean, we know that the wire of the circ is trapped, so it's just stuck on the place that you say, okay, there is something wrong there, and you don't need to push, especially this kind of balloon. But it's also
There is some resistance.
hit
Yeah,
there.
no,
it's
was-
good. It's good.
Okay,
Perfect.
but it goes. You have to be gentle, as you said. Let me just see a little bit without contrast. Okay, give me a little bit of contrast now. I think it's okay there. Maybe a little bit more distal.
Maybe a bit more distal. Yeah.
Yeah. Okay. I think it's
Okay,
good.
this is good.
Yeah,
This is
go
good.
now, go 6, 8, 10, 12, 14, 16, 18. All right. Down. Give me another wire now. I will dilate a little bit more proximal. Yeah, let's have a run through. Go to
Yes,
16,
John.
18, Dr. Jeleva, also to flare the ostium of this stent better.
18,
20.
20.
Down. Store. Okay. Big
So,
balloon.
going with a third stent is a good option because it's better than to remove the main vessel wire and to come back to go to the circ because you lose some support. As you can see, we cannot have strong support because we cannot intubate. So coming with a third stent is a good idea. Was suggested years ago by my associate Marie-Claude Maurice. I adopted very well this technique.
I'm not entirely sure what kind of curve I have there, but let's try to do that.
But we have another...
That's okay, let's try. I mean, everything is in a relaxed fashion here. I'll just try to see whether something works nicely there.
Wow, directly the distal cell, wow.
It's a very good wire.
Yeah.
And a very poor operator.
I will say, yeah, exactly. No, a very good operator, I think.
Thank you.
This is not complex at all, for you.
So, I think we should feel confident. I was trying to get in there with a knuckle. But
yeah, perfect. Yeah, that's a good idea also.
It goes.
If you go with a knuckle, you don't go outside the stent.
No, for sure. I think it made a small knuckle and went down. It's okay. We will just feel better. So this is the LAD anymore.
May we have a? I know we have a angiographic control already.
I'm going to make a control for you now.
Yeah.
Let's do that.
Thank you.
Go contrast.
Yeah.
Sorry about that. I haven't used an JL4 for some time. Okay, let's make it again. Film.
It's beautiful, huh? You can see, of course, you have a carena displacement.
Yes, but that's okay.
But this is not a problem, huh?
No. But you see exactly the points that we mentioned. The fact that we have a port that is geographically visible. We didn't lose any branch. We followed the right strategy for the circ. So, let's take a 2.5 balloon.
Just a comment on the carena. You see here, we see very clearly that this is a carena displacement. You see?
Yes.
Because this is coming from distal. To occlude the vessel, you need normally plaque shifting coming from proximal plus carena shift.
Yes, 3-0. No, can see, normal. So, I'm going to take a 3-0 balloon to flare it.
Yeah.
Dobry has a comment.
And then...
Can I bet that if you do FFR on this circumflex, it will be negative?
This is well known phenomenon.
That's a good question.
Yes,
it's a good question. It's a good question.
This is quite possible because we did not find any.
I think you have
the ostium of LED with IVUS.
I think you have the result on your EKG.
Dobry, you think that it might not be necessary to stent the circ?
No, but this is just a catch.
Okay.
Because we are on the educational course, and this is why, because so many people are looking at us. By the way, with Dr. Bong Kwon Koo, we had a lot of discussions about appearance of displaced carina and FFR significance of those lesions. Mm-hmm. And what we both noticed that when there is such type of carina, which we called S-type, in almost all of the cases, it is not significant.
Okay.
When it is V-shaped, just almost in all of the cases, the stenosis is functionally FFR significant.
Okay. Mm-hmm.
So this is why I just made this notion about the FFR, about the ostium.
Okay.
Maybe you need a small balloon.
I will. But as I said, that's why we chose this compliant or non-compliant balloon.
Compliant.
It's a compliant. Okay. I tried. Sometimes coaxiality is better than backup. I will just see what it is. Simply, JL4 is not helping. But anyway, let's see. I will try to remember the old good days. So, but it's also 3.5. So in that respect is
3.0.
No. The guide is 3.5.
3.5, yeah.
So you see that we don't have optimal backup because in the past, in my very early days, I was doing. So we'll have to take a smaller balloon. Let's take a 2.0 balloon just to see how it will behave. Okay. Yeah, I found it very strange that it is not going. But anyway, I would expect an easy crossing there. Just a second.
Me too, but we have seen
surprise to me.
We have seen calcium, George.
Yeah, but you see calcium, but I didn't really enter because sometimes you have the feeling when the balloon is going. But I do believe that the guide is an issue here. Of course, it was chosen probably because it was a diffuse left main and this and that,
and a short
and very short left main. So there are advantages and disadvantages that you always consider. So we'll see how this balloon will track. If this doesn't track well, we'll see what we're going to do. I'm curious. Okay, give me another wire.
Другу дай.
So there are different things that we can do here. First of all, what I'm going to do is I'm going to recross.
Yes. Yeah,
another balloon.
Go to a different cell.
Yeah. If this doesn't work, then we're going to do anchoring. Or if this doesn't work, then we're going to do IVUS. Correct?
Yes.
Because what you suggested is very important. Even under the circumstances that we said, there is no way that we didn't exit the left main. So, because what you suggested and we follow it gives us a certainty that we are not outside behind the strut stand, at least at the ostium. That's for sure.
Yeah, what you can do is to prepare your balloon already on your wire, so you can test this different position.
Yeah. So let's see how this wire will behave, and we will take it from there. This was the intermediate.
Yeah,
okay.
Good.
First of all, we cross in the direction of the stance with a knuckle. That shows us that we're okay. Then I'm going to turn and try to enter the left main, the circ, without getting out of the ostium, if I can. Give me a little bit of contrast. I'm more distal than I should. What you should not underestimate, this circ had a kind of tortuosity. Of course, we crossed it. I'll pull back the guiding, especially this guiding. I will smoothen the curve out there just to be able to see whether I have any advantage of guiding this wire into the right place.
So what kind of a wire is that?
It's a run-through, I think. It's a run-through, isn't it?
It's a run-through, yeah.
It's a good wire. It's a hydrophilic wire.
Yeah, good.
So do it gently, don't rush.
So you have the balloon now, you can just test if it's crossing or
Yeah,
not.
we will see how it goes on, and then if it fails, then we're going to see what we're going to do. So give me the balloon again. We follow some steps. We have the luxury that we're not in any big rush. Yeah, no problem.
As a buddy.
So
Good.
inflate there.
Shall we remove
The
other wire from circ?
Yeah, we can do that. Let's go a little bit more distal. So there are nice things that someone can do. Just follow some very simple steps, and then, as you see, without any big things, we are. Go there, 16, 18. I will take also the 3.0.
18.
Okay. And down. Save, please. Give me the 3.0 balloon.
Тройката.
Okay. It goes smoothly. We're just going to go now because definitely I need the advice of Eve about the top, about the way that we're making the top by imaging.
Just a point about this T on top. You can do a T also, but it's not depending of your choice, in fact. It's depending on the fact that you enter the distal cell, so projected some metal in the circumflex.
But that's exactly
so you can
what
do
I
a
was
tap.
talking
You can
about.
you can do a T.
Having
You
there,
enter proximal, and then you have to do a tap.
Having you there, it gives me a comfort to understand the technique better, Yves, because in this case I'm going to follow exactly as you suggest. Down?
16.
Yeah, it's down. It's okay.
So we will know now. We'll do an angio there. We'll know now if you have some metal in the circle.
All right.
Have you stent enhancement?
All right.
Valérie,
here?
have you a stent enhancement?
Boost?
Stent boost?
Yes.
Stent boost will be nice.
But,
Maybe even better than angio.
The balloon.
Okay. Let's leave the balloon then, and we're going to do some stent boost, and you're going to tell us how, because it's very nice that you explain the entire thing, and we're going to follow your guidance, so everybody learns how to discriminate when he wants to do tap and when he wants to do T.
Okay. By the way, you have IVUS on the table, so you can just do IVUS in direction to the circumflex. And if the angio result is good, without huge dissection and so on.
I think we should make a kiss and after that, because we have compromised a lot of in the stent.
So can we see what we have here?
It's in progress. It's going to.
Okay, let's see what we're going to do, because it's a very nice opportunity. You see the distortion at the ostium of the LAD that was not fully expanded, of course. So what do you suggest now, Yves? What do you suggest?
Just show me the stent enhancement.
You cannot see it, eh?
Yeah.
No, I cannot see.
Завъртете това нещо.
Can we put that in the... Yes, that's good. Okay.
Там долу на беличкото да се фокусира.
Yeah, just a bit. That's coming. You have something just in front.
Okay,
you can remove.
we move the screen a little bit further because they're disturbed by
the other way. Yeah.
The other way.
Okay. I think we see here that we have strut in the ostium of the circ. You see?
Say that again, Yves.
So you have a strut which is in the ostium of the circ. I see it.
Yeah.
I see it. So
exactly.
you can do a perfect millimeter by millimeter T-stenting. Of course, you put your stent in the circ with an uninflated balloon in the LED.
Okay, so we have to explain to the people.
And you can even use a second stent enhancement to see the position.
We will do that. So what you're suggesting is, because I wanted to just stress a little bit more clear to the audience, exactly in the middle of the balloon, we can see that one strut stent is protruding in the direction
of the circ.
That means that we did a distal crossing and that we have the space to do T and not tap.
Yeah.
Okay. Give me the image again.
When you are sometime in a core lab, to see the difference between T and tap is a bit difficult. But the principle is this one: don't do inadequate, don't do unused, no protrusion which is not necessary.
Exactly. Give me a 4.015 non-compliant balloon first, and a 4.0 by 18 stent.
Which stent is
Stent 4018 and the balloon 4.015.
Shall we make a scene?
Say that, Valerie?
Shall we make a scene just to see?
No. I don't think that we have anything to see. So everything is under control here. Yeah, I think it's. I think I'm okay with that because we measured the vessel. We can see the vessel diameter before when we're doing imaging there.
Just a question: what was the diameter of the woman diameter from IVUS of the left main at the proximal part?
The proximal part of the left main.
Yes.
Yves calculated that based on the.
That's fine.
No, you have IVUS.
4.0 plus 4.0.
We will do that.
That makes 8. That's
after standing, we will do IVUS.
Yeah, 5.5.
I mean
5.0, at least 5.0.
Exactly. So you placed 4
This is the
stand
balloon first.
NC, no, NC.
NC. I
without
want
doing
an NC.
pot with 5-hole balloon, and now you have something interesting in the LED ostium, and also you plan to do what?
So I'm going to put first a
You can do a pot with 4-0, 2 short balloon with only, summation of the 2 diameters only in the polygon, you know? So put the LED one a bit distal and the circumflex a bit proximal.
Let's go to 4. Okay, this is a 4-0 balloon in the DLAD. All right. Give me the 4.0 stand now. We're going to go low pressures and then we'll...
So what we see today, this afternoon, is that we can do very complex stanting without decay crush. At least a fabulous operator like George Janos can do it.
I want this video for my records.
Yeah, and send me too, if you agree, please.
Thank you.
To show that we can do complex with...
This statement I have to show to
we can do simple for complex.
I have to show this statement to my children and my students. Thank you. Okay, let's see how the crossing will be now. I don't expect any big things. Okay, it went smoothly. Yves, guide us again. So
I think
again, stand enhancement or stand
the position you are here, do instant enhancement.
Okay, we will do that. So I don't want contrast. We will do that, and we're going to do this without contrast. And we're going
I think it's good position. Try it.
Me
Maybe
too.
more
Okay,
proximal, but
it.
try it. We'll see. I think
that
it's good.
we have to go a little bit more proximal.
Half a millimeter proximal.
Yeah. But let's have, because that's the beauty of imaging. It will allow us to judge it. Let's take step by step.
Can you show us again the monitor of the
what?
stand vis?
Yeah. To see the
Yeah,
stand.
when we have it, we're going to show it to you. Just a second. It's not ready yet. Let's have it and then...
Maybe it's good, huh? We'll see. Maybe it's good.
Okay, put it on the other side. I think, as you said, we need 0.5 millimeter back.
Yeah.
Or you think it's okay?
Oh,
Back.
no, I think it's good. I think it's
A
good
little-
because just under the marker of your side branch tent, you have a spot of a strut.
Okay.
If you see,
All right.
I think it's good.
Yeah, if we go for a real T, is okay. Dr. Jeleva, turn the screen. All right, let's go start inflating.
Shall we put the other bone in place?
No, not yet. It's a real T, nothing will go. Let's inflate the stand.
6. 8.
Yeah, perfect position.
Okay, down.
There was a severe lesion in the ostium.
Okay, down.
Then you put the other balloon and you do kiss.
Exactly. Now, what I'm going to do, first of all, is that I will pull back, of course, all devices in place.
The wire in the circuit is
Yeah,
too
it's
deep.
okay. Let's correct it.
I think the best will be probably to put the circumflex balloon
Yeah, we're going
in position
to
as it is.
and then we're going to do
And-
sequential kiss
Yeah,
inflation and then
And
final
LED,
kiss.
no, don't go back to the ostium with the LED. You will ovalize. Push a bit.
Say it again. Yeah, why not?
No, the LED balloon, you will ovalize. Of course, you will do a last spot, but I think I will summarize the 2 diameters only in the polygon of confluence. So to do that, you have to push the LED stand, the LED balloon.
Yeah, distally.
Distal.
Or push it distally, yeah,
To
the LED
have
balloon.
this only the polygon of confluence inflated.
All right.
A bit back. No. Just come back. We do a kiss, a bit back. Again, a bit back also on the circ.
No, Selk, I will correct.
Yeah, a bit back for LED. I think high pressure, you can go there.
Okay. Go to the circ first.
Where is it?
Leave that one.
Where?
I think maybe put pressure on the LED because there is a residual lesion in,
How much you have?
6.
in ostium.
No,
Huh?
we have to go higher. But I was going to do it more classical. You don't want to have a good kiss, eh?
Yeah, we will have a good kiss. We will have a good kiss.
Okay. 10.
Go higher pressure maybe on the LED.
Higher pressure.
On LED.
16. We have 10
okay.
in the LED and 16 in the circ.
I think we can deflate now. I will look at the... When you have such big balloons, you have big gadding, fortunately, but
Okay.
when you have to remove
So-
big balloons, you have to wait for complete deflation. Huh?
Yeah. I think I should do also, do a kiss
Yeah,
like
you
that?
can do that, and the
That's
final
good,
pot
yeah,
with the
I
5
want
will
that.
be perfect.
Yeah, I want that. Okay, let's go again. We will go to 12 together. $14, Dr. Jeleva. Saddle shape down. That's good. Okay. We're going to
So the waist you see at the bottom of the circumflex balloon now is because you have reached the maximum expansion in this very large,
That's what it is.
polygon of confluence, much bigger than the other vessel. Yeah.
Okay, so we're going to remove both balloons together. We're out, very nice. I lost the wire sequence, but we're going to check it. Do you want to see an angiographic image?
Oh, yes, yes, yes.
Okay, Phil, give me a 3O balloon first.
Една тройка NC.
So this is a perfect decay crush, no?
What I'm going to do...
The 5-0 in the left main, I think will be, but don't go to the carena.
No, we will do 5-0, but we will do IVUS first. I will optimize the distal one.
Oh yeah, yes.
Let's make, I want that we make a stand enhancement again. Give me a balloon of 3O non-compliant.
It's coming.
Uh,
I want to see the metal architecture with stand enhancement. Okay?
Yeah. So this is, if you have this technology in your cat lab, this is very, I won't say, I say sometimes, but
And
this
is
is not real. It doesn't replace intravascular imaging, but can help you not to use intravascular imaging.
Yes. So I will put the balloon in the direction of the LAD. Then we will optimize the LAD with this, and then I will take a 3-5 balloon for optimization of the LAD, and then we'll do IVUS.
So easy, huh?
Very easy.
Very easy, huh?
Very simple procedure.
Very easy.
Spectacular result.
Okay. Dr. Jeleva.
You just made 3 or 4 seconds of cine.
Yes, okay.
And this is just you have to push
Yes.
a button outside.
Okay. No, what I mean is that you have got excellent images, so it gives us good pictures.
A big screen. It's becoming
So
more and
we're
more.
processing now. I'm curious to see how the metal architecture will be looking like.
This is ready.
It's not very clear image, no. Not as previously. Should we do it again? Or should we do
We
it with
can't
the balloon
see-
in the
we
direction
can't
of the
see.
circle?
Push the balloon a little
Maybe
bit.
the balloon in the circle, maybe.
Maybe.
Yeah,
Not
okay,
sure,
let's try to do that with the balloon in the circle.
Okay, going.
But it is just to make the audience happy, huh?
No, but I think these
optimum.
are essential.
No, this is very important. I
These
understand.
are essential steps as far as because then from all of these you get the sequence of how you do this, and I do believe that
Yes, it's important.
I do
Another-
believe that very few people know well in the general practice. I mean, Yves, that
But I have to say-
how to angiographically judge about how to choose TAP versus T.
Yeah, I have to say, George, that now since a few years, we have pictures like this in bench or in simulation now on true patient anatomy that will be published soon by Yanis Chadzizizis.
Okay.
So this is something we can
Okay, we can
reproduce in a
exchange.
simulation.
No, we can take the balloon out. The stand piece is going to be.
No, simply I just want to see whether it is good or
okay,
we repeat it or whatever.
you're
and then
right.
we will change that.
Do you think it's essential to correct this pinching of the stand at the ostium of the circle?
Yeah,
Is it
we were
possible-
waiting to
is it
see it better in
possible to have a
yeah,
spider view?
Of course we.
Okay,
we-
look at that, how it looks like.
Can
We are going to do...
Can we see the stand vis
yes.
picture? Yeah.
Because there is a compression of the ostium of the circumflex. There is also compression of the ostium of the left main.
We are going to go now and we are going to do IVUS.
Yes, because stand vis is not good when there is too much metal and there are two wires, so it's a little bit, it's very difficult, let's say so, with stand vis to have a good picture, but I would like to ask you just for one simple angio in spider view.
We will do that for you.
Oh, you can do this one also. We have not
Let me
seen.
optimize a little bit. I have the balloon in. We will do that. Let me just dilate the stand in the LED, the distal part of it. Sorry. Go,
Yeah,
Valerie.
we see
Nice.
even here we see
Go.
a small under expansion at the circumflex.
16.
At the circumflex. So what we can do for the circumflex is to come back for another kiss. And you remember we did high pressure in the LED, but not in circ. So you can go back.
No, we went up to 18 also in the circ.
18 also in circ.
Yeah. We
So
did
you
that.
can go.
16, 18, 20.
You can go in circ at 1820 for as long time as you can. After that, do an inflation in LED. So
We're going to do something different. We're going to do IVUS now, and then we're going to optimize in these directions and see the difference. 16, 18, 20. Okay, down. Should we take a 3.5 before the IVUS? 3.5 balloon, 15, non-compliant. Okay, so we dilated now the entire length of the of the LED up to the way to the bifurcation with 3.0, but we know that the proximal stand is 4.0. We're going to take now we dilated the proximal part of the LED with a 4.0 non-compliant, and we are going to dilate now not the very distal part of the stand, but the middle part of the stand with 3.5, and then we're going to do IVUS, after spider and IVUS. Okay, Dr. Jeleva, let's go there to 16, and we'll go, and let's start preparing also the IVUS. I'm going to do, I'm going to do first, which vessel do you want an IVUS first?
16.
Say, fluoro. Down.
Maybe spider view first.
We will do that, but I'm just asking, which vessel do you want to see first with IVUS?
It doesn't matter.
I know why Dobrin is asking that. Is what there is probably a remaining plaque, a carena shift. And this is the ostium of the circ now is oval. And if we look in another projection, you may see a perfect result. This is
We
already.
will do absolutely that. Down. I will start on the circ. Can we move the screen to get a good spider, please? I think the stand of the LED should be okay now. We should not be anything unexpected as under expansion. Let's focus now on the bifurcation. Let's do a good spider now. Should we measure an ACT also, just in case? I want more spider. This should be a good one, eh? Yeah, I think that's a good one now. That's a good spider.
Maximum caudal.
Yeah, but we are around 60, doesn't go more. Okay, give me a little bit of contrast just to see what do we have there, if we have a good imaging. That's good. Okay.
Maybe less low and more caudal.
No, this one is good. I have seen the
I think
results.
it's
You can
good,
go.
but I will just do. Oh no, maybe. Okay, we will take both of them. Phil. Contrast.
So look,
okay.
the tight lesion at the ostium of circ disappeared. So this is a novel because the carena was a bit pushed.
In this
What
case,
you see,
in
this
this
is perfect
case,
for me.
You can see, yeah, for me too. You can see the overlap. Just, Dr. Jeleva, can we collimate a little bit?
Yeah, we have a small overlap. That's true.
Which is just right. Let's collimate a little bit, and we're going to make.
Yeah, so if I have in my core lab, I can say this is probably a tap. But you know, it doesn't matter.
No contrast. No contrast. I'm
Yeah,
not
we
sure.
see the small neocarena of a tap. Yeah,
Yes.
but this is not a problem.
No. So.
The most important, the ostium of the circ is fully covered by.
Yeah, absolutely. We have metal overlap in the entire vessel. Minimum, maybe minimum neocarina. Let's make an IVUS, please. Let's start from the first.
Да.
I'll take now the SCT first. I'll do it.
Колко време сме взели? Сме
Аз
минали?
съм направил още 2500 преди около 20 минути. Този трябва да сме окей. Съжалявам се малко.
I'll take it, Valerie. It's okay.
Позволявате да се стирам, за да може да натискате.
Do we have the?
Още не ръкавички.
Okay. Okay, let's clean a little bit here. Do we have any green thing here? Do we have a green to put here or something like a little bit of something?
Дайте едно...
Okay,
чашавче.
let's go now to do an IVUS. So we're going to see what we're going to see.
Ники, набута и това напред.
All right. I think we're okay, Dr. Jeleva.
Yes, exactly.
So let's see that one.
Record.
Okay, can we go back to the IVUS imaging, please?
Тук фокусирайте.
Thank you. Okay, I'm ready to pull back now. Should I start?
Yes.
Okay. So this is the circ, the distal circ. Can you see?
The stent.
Yeah.
So I think the 4.0 was a good choice,
Yes.
Yes.
and maybe it needs more dilatation. Even 4.5. Here the vessel is bigger, of course. Let's see now exactly where the carina is, whether the stent is not well expanded or not. I'm going very slowly. You have a Greer imaging? There is that's exactly the point of the, you see it?
Yeah.
Yeah.
That's exactly the point of the carina here. And we see that certainly the stent in the circ is not circular. There is a small overlap, as you see, which means that it was tapped. This is the stent in the left main, which looks good. It even, as you said, with a 4.5, there is a good position.
Yeah.
And we protrude well into the aorta based on the upper rim, and this needs certainly a 5.0 dilatation. Stop. So, Dr. Jeleva, as you're making that, I'm going to insert it into the direction of the LAD. Can I have some sponge, please? Just give some visibility for the IVUS, because people don't see. Can you see the IVUS now or not?
No. No.
Can you see the IVUS? No. Okay, let's leave some space for the IVUS. It's okay. Come. Or next to me, or open it. Now you see it or not?
Yes.
Yes, we see.
Okay, that's great. So let's focus there just to see what we're going to see.
7.7 minimal stent interior distally.
2.9, 3.3.
I think that the circ needs some post-dilatation, the distal part.
Yeah.
We will see about that.
Yeah, because the diameter 2.9, 3.3, so it was a 4.0, so maybe you can improve a bit.
This is 2.9, you want 3.10.
We can see the measurements, maybe.
Yeah. Because we went low atmospheres there. The stent is getting bigger now. This is the point of post-dilatation.
This is the kissing.
This is the kissing area. The distal one needs a 4-0 dilatation. Let's see what we achieve with kissing there.
4.6.
9.6, 3.6, 3.4, which is acceptable.
Yeah.
It's getting even bigger now. And this is exactly the point that we start seeing a little bit the LAD. Stop there, Valery. You can see the anatomy of the stent of the circ.
Yeah. You may see also
Maybe.
from LAD to left main pullback.
Yeah, we will do that. But do you know what I think here? Should we convert that in a mini crash? Or
No.
Internal
What you can do,
internal
look at what you have on ostial LAD, because the last thing you did was to optimize the proximal LAD. So maybe you pushed a bit the carina. So look at what we have on the LAD, and if you can, we can put back the two balloons and reposition the carina. We'll solve the problem.
Why don't you take two very short balloons, 6 or 8 millimeters, just do the kiss.
For the kiss,
polygon, or the polygon of confluence only.
Yeah.
Then to repeat IVUS, and if the ostium of the circumflex and LED are more than 5,
can we
6
just start
millimeters,
running again? Give
just
some
leave it
space to the people to see it. We are in the LAD now. Okay. Distal LAD.
You can make the pullback.
Yeah. So that's the stent in the distal LAD. We went with a 3-0 balloon there. It's not bad. Should we flash the catheter a little bit? Or it's not to be flashed, okay.
С контраст малко.
No, it's okay.
Не контраст,
It's getting better
течност.
now.
Вода. Да.
That's okay. So we are there now. This is the 3.5 dilatation, the 4-0. Maybe we need some more push in the distal part. We went with 3-0 by 18, but
Are you in the left main?
yeah. So actually, I'll go a little bit deeper because I didn't see the circ. So this is the proximal LAD, correct? Here is the circ.
correct.
Yeah. It's,
We don't get much information, but you see
No,
that.
but see
yeah, but we have seen that.
Neo-carena, there's a neo-carena.
It's a neo-carena.
Absolutely.
You can
Decay.
redo a kissing, but emphasizing the circumflex. I mean, high pressure in circumflex, low pressure in LAD.
So
You can do, but
what kind of balloons do you want?
You can do, but 4-0.
Yeah.
The last time we dilated the LAD was 4-0 or 3.5.
No. We have 2 times. Oops, what happened here? Okay. We had 2 times 4. The final kiss with 4-0, but it was the balloon of the stent and the 4.0 by 15 non-compliant. Let's take 2 times 4.0 by 8.
Yeah, I agree.
Okay,
Yeah.
let's do that.
Or 6. Dobrin was suggesting 6, so.
If I don't know if we have 6.
Ah.
No, 2 times 408 non-compliant balloons, please. Let's see again the image here.
But the strut you see in front of the circumflex, if you know the practice, for example, in Korea, they don't remove it. They don't remove it at all. They don't touch. They leave in front of the circ.
Say that again, I didn't understand. They don't touch what?
Dr. Park is not removing these struts that are close to the carena.
Okay. So let's see what we're going to achieve now with this dilatation. The diagonal also needs some checking. It has symmetry flow, but I will see it a little bit. You see the ostium of the diagonal also?
The diagonal is small, and there are several diagonals, so if we follow Bonkonku, none of them is relevant.
Not the first one, the second, I mean, which is 2 point something. So let's see what we have here. That's a circ. Okay, give me the LED first. I think this is a nice demonstration that shows that even the simplest left main, it has a science behind this that has a value. And I think in this case we clearly see all of these concepts because we didn't even have the slightest problem to do the stenting and follow all of these things. And I'm pretty sure that the majority of the people would have finished the procedure here. But we clearly demonstrate that this is suboptimal.
And we all know that we cannot achieve a perfect result through the stent struts, and there will be an oval shape of the circ anyway. We're just going to optimize it.
We're going to do now a sequential dilatation. We're going to go to 20 atmospheres in the circ, correct?
Yeah.
And then kissing with how many?
Yeah, you can, if you do high pressure in circ, then you can do a kissing with down to 10 atmosphere, you know,
Okay.
just.
Actually, here the
Yeah,
intention
yes,
of
perfect.
kissing is not to dilate but to reshape.
Yes, of course. Okay, I think that's good. Go to 20.
So the protruding strut, this is coming from tap, and it's impossible to remove.
22.
You know, but you can align that with the carena, not push it in the circ.
No. As you see, I'll pull back now the LAD. I will correct it because there is an action reaction in the.
Look at the strut. We see the strut at the carena. They moved.
Yes.
They moved back to LED. So now we are sharing probably better the flow.
Is that a good place?
Yeah, good place. You go up to 10. It will be enough, I think.
Let's go together. So not very fast because they're going to be.
Yeah, good.
Okay, 10.
Stop.
All right?
Yeah.
Down.
I'm just wondering how much work could be saved if he just stopped after kissing.
Okay, I'll give you a film without any contrast, no contrast. You see? It looks much better, I think.
Yeah, it's better. Yeah, it's better. So you will have probably two struts. Yeah.
Prepare a 5-0 balloon.
So it's a tap.
508. Should I make a film?
Yeah,
contrast? We will repeat the IVUS in the circ. Let's make a film with contrast.
Just for a discussion, I want to ask, do you think that we need a double antiplated for life?
Sorry. Just we see the film and then.
Okay, should we do it? Yes. Okay. That's okay.
You see that the strut have changed. They are now better oriented towards the LED, and they open completely the ostium of the circ. So I think it's good, really.
We're going to do an IVUS. Let's do an IVUS now. Or let me dilate the circ, the ostium of this left main with 5-0 first.
Yeah.
I think it's necessary.
Wait, and we.
For life? Certainly not. No. In my place.
Okay.
Will be 6 months. But I can accept that 1 year is reasonable. So, but maybe you go back to you suppress the aspirin at 1 year, and you have a single ticagrelor, I don't know, something.
CT or something after a while.
We were doing that in the past, doing follow-up with CT scan at 6 months.
This is the new balloon or virgin balloon? Or?
No, it's a new balloon.
And don't go close to the carina. You will crush the carina.
I don't want that. I think.
So this spot is different from the one we do.
No contrast.
Yeah, it will be. It will be.
Push
a bit. Pull a bit.
I will. Simply, they are big devices. Okay, go
okay,
back. 16,
this
18,
is good
20.
here. Yeah. Yeah, good.
Okay, that's good. Down. That's enough.
Turning back to the question of Dr. Velchev, I mean, Vasco, turning back to your question about
let's
the
go and do that.
I think the metal is not overlapping here. There's not a lot of metal strut. There's one strut, so probably maximum of 6 or 12 months, absolutely enough.
Yeah. Consider this guy suffered acute MI a year ago.
So you have to go on with the double antiplatelet treatment if it's 1 year.
Dominant diffuse disease, so we have a lot of potentials for progressing of the atherosclerosis.
Yeah, but he has also a lot of potential of hemorrhage.
But double anticoagulation is not for the progression of the disease, for the acute thrombosis. So he have to change his style of life, not to.
No, I think 1 year is. 1 year, I will accept 1 year. It's okay. 1 year, you can even keep the ticagrelor or another of the antiplatelet treatment alone.
That's why I think that it's a perfect candidate for low dose ticagrelor after 1 year.
Maybe yes.
Yeah.
60, yeah.
That's a Pegasus type.
60 milligrams.
Yeah,
twice,
and you suppress aspirin, so you have not a stomach problem.
Yeah.
All right. The time of truth for the ostium.
So what are you doing, Ivers, again?
We did the 5-0 dilatation of the stent, just of the ostium that was hanging into the aorta a little bit. And then I think that should be enough to improve that. And we're going now into the direction of the circumflex with Ivers, just to check again the ostium of the circ. And I'm going to take a 4-0 balloon just to dilate a little bit the distal circ. Without any further imaging, we're checking out only the ostium of the circ there. All right, it should be okay.
Are we ready?
Can you see it?
No,
Yes.
no.
Should I pull back?
Now see.
Okay, we're pulling back here. I don't know why. Okay, that's good. Certainly we need to improve that. For sure, we will do that with a 4-0 dilatation. We're interested on the ostium of the circ here, just to see how things.
Okay, it's much better, no?
Yeah, I think so. This is the
It's
left
still a
main.
bit oval, but it's much better.
But I think also the left main looks much better.
Yeah.
So I'll go a little bit. There it is. Again, I'll come back. No, the left main, let me go, there it is. I think there is the ostium, and I think it's much better there, correct? It has been substantially improved compared to the previous one.
Yeah. Because when you do a kiss, you can push the carina, the two struts we have seen. You can push towards the third, towards the LED.
It's more circular now. Okay,
So,
give me a 4-0 balloon again, the short one. I'm going to dilate the distal circ. And then we're going to make final filming here. To check also the diagonal. And we're going to do afterwards some filming, and more or less I believe that we did the very best that we could do in this case. Hold the wire for me. I have it.
You can judge about the ostium, so if you see how this inflated already, four bone is passing through.
Okay, go there, 10, 12.
Yeah.
Without any resistance, so it's...
Okay, down. If I will remind you something that you don't forget, that you might not remember, 16, 18. So we were together in Dubai. No, I'm distal from Dubai.
Take care not to do it too proximal,
No, but let
not
me
to
show
push.
you that I'm distally.
Because if you push towards the LED, you will,
but it
will
was,
see the strut on
it
the other
was
side.
clearly distally.
But
So,
you were here with high pressure during the kissing. I think.
so in that respect, so we were in Dubai, and there was this big meeting organized, and you have to leave. You remember? I
Yeah,
think
yeah.
Your grandmother, and then they came and asked me, "Sir, Dr. Luval left. Do you know how to do bifurcations to do this case?" So I said,
Of course.
I'll try.
Of course, in you.
But it's a very big thing, the perception of the people in your face, huh?
Yeah.
Okay, let's make a film here, please, with contrast.
That's good.
I am very happy with that result, to be honest with you. I don't know what about you.
I like it, yeah.
I think we have a very good result over there. Let's see a little bit how the diagonal is looking like now. Okay, let's make another film. Film. I think it should be okay. What do you think?
Yeah, good result for me.
We have a good...
Cannot do
flow,
better.
No
Yeah.
complaints.
Yes. So I think we can accept that, correct?
Yeah.
Do you agree?
Exactly.
Yes, yes.
This wire is not going to go into the diagonal. It's
Let's
And,
not go into the diagonal.
Please,
not go.
please, George.
If it's not necessary, let's not go.
No, thank you very much. It was a great pleasure. I don't know if there are any comments, final closures of the case. I think it was, thank you for the very nice discussion and the structured guidance. Dr. Jeleva, any comments?
No, just wanted to mention that an excellent decision and teamwork, I would say, for this complex bifurcation, because it was very, I think, very educative. And just as a comment, we have the measures from the IVUS. Circ, even before the post dilation, is more than 9 square millimeters minimum stented area, and AOD is around 7 above. So I think we have a good work done. And now we of course, we are going to follow the patient for according to our protocol after 6 months and at 1 year.
So,
George, Valerie, I have a
were you
question
go-
for you. I have a question for you.
Yes, please.
Can you, both of you, send me a copy of this?
Yes, of course.
Because now, you know, you made me missing of the catheter, so I will look at it at home.
Okay, okay, we will do
If
that.
there are some patients, you can come down and...
You can show us the tricks, the job. Again, thank you very much, Dr. Jeleva, Dr. Vasiliev. It was an honor. Thank you very much, and we'll come up to see you.
Thank you.